for this evening talk and evening lecture.
Thank you. Thank you.
And thanks for coming in and listening me talk about the concept of surface-guided imaging and surface-guided radiation therapy in general. And I just want to walk you through what the concept is. Treatment planning, as well as the monitoring of the dose directly during delivery. So I'm hoping you to see kind of a radiation therapy in the same lens as I do over the last 4 years since I've been with Vision RT, and just to show you the incredible development and this technology has been influenced over the radiotherapy field. So the concept of surface imaging, so if I can change my slides. Yeah, these are a bit of a disclosures from me. So I'm, of course, the technically Vision RT employee. I try to do this public, this presentation a little bit impartial to include all other vendors as well. But to be fair with you, my initial or most of my clinical experience are from Vision RT products and how the Vision RT foresees the SGRT space as it is. I'll try to be impartial to my best ability, but if you want some of the more data about what's out there in the competitor products, it's better to actually directly contact the vendors or just ask the questions in the chat, and I'll try my best to answer them. My viewpoints here do not necessarily represent Vision RT's commercial viewpoint. I have to say this as well, but I'd like to see and represent my let's say, viewpoint, how this is reflected on the modern SGRT development in the field. This is a bit of an outline of my talk. I'd like to talk about the overview of this technique and surface guiding technology in radiotherapy, and what are the vendors providing those, what are the current clinical practice utilizing those solutions, and I want to talk a bit about, mention the quality assurance of the systems, innovations, and what are the challenges associated with adoption of this technology, radiotherapy, and what type of value does it bring for like a clinical adoption in a clinical setting. Just to talk about the basic principle of surface imaging, this is what it looks like. So you have two main components in this type of solution. So you have a projector. It's usually a light projector that gives or projects a bit of a known structured light, or a bit of a texture onto the surface on the patient's body, or it could be a patient, it could be anything else. It's also used this technology in kind of a industry-based solutions. And then you have a camera that detects this pattern and distortions in this pattern, and then can reconstruct this as a real-time 3D surface. So at any point on P, if we see on the patient or on the object that's projected by the projector, this can be reconstructed by the cameras as something we call disparity map. And here's is a picture from the publication down there recently. So just to showcase you how this is done in a clinical setting. So we have here this structured light, we have a camera, and it's a purely mathematical concept of triangulating this point. So it's basically a triangulating this point on the patient surface. And here is, let's say, a line T concept in a single pod. We have a projector here, and we have a camera, and by knowing those distances, we can kind of triangulate the location of the point on the patient surface. So we utilize it in radiotherapy. So this let's say in a clinical setting looks like this. So some of the let's say, SGRT vendors. Most of the SGRT vendors use this approach. They utilize this pseudorandom speckled pattern, so it looks like a QR code if you just look into it. And there's a projector that gives or shines this light with a bit of a structure on the patient's body. And by introducing this distortions in the field, in the light field here, by putting the patient here, we can see what is the curvature and what are, we can triangulate every point on the patient's body using this. So this is quite a nifty technology. Has been used previously before it entered the radiotherapy field in manufacturing, because we can measure very precise details with those cameras. And if we are doing the precise detail manufacturing, we can actually do a quality assurance using the optical systems like this by detecting the surface and defects and everything in manufacturing process. So idea comes from there, but then it kind of takes its roots into the radiotherapy. This, in a, let's say, a clinical sense, like if we are talking now about the SGRT system or surface guidance in radiotherapy, this is something what it looks like. So you have here and two sensors. So in the pod you have two sensors and also a projection unit that projects the speckle pattern. So each of the cameras see kind of a different view a little bit, because they are rotated, tilted with respect to each other, and they work around the same stereoscopic imaging principle like your eyes do. So for example, if you have, you think about your eyes are also looking at the same object from two different angles, and they know from here, so your brain does the calculation, the brain knows what is the distance between yourself and that specific object that you're looking at by having that stereoscopic stereo vision. The same principle works here, but in a mathematical algorithmic sense. So we are giving a patient's body a bit of a texture, and then this is then reconstructed by the mathematical algorithm as a real 3D surface. So we can have multiple different cameras and types of cameras, but they work almost alongside the same principle of detecting and visualizing and reconstructing this 3D surface in real manner. You can have multiple different types of projections onto the patient surface. This is a very nice review paper. By the way, this is not for radiation therapy. This is more for like stereo vision and from the optics photonics paper that talks about all types of different techniques and speckle patterns are used in industry to kind of discern a little bit of the patient surface. So in a clinical sense, we utilize the monochromic pattern. So we don't use the, let's say, pattern that has the different light mixtures inside, like a rainbow here. And this monochromic pattern usually is a different color projection. So some of the cameras, like let's say Vision RT's cameras, those projection and the cameras can be infrared. So this would be completely invisible to your naked eye, so you won't even be able to see that it's those cameras are on or are projecting the light to the patient surface. For some type of the cameras, it can be a bit of let's say some light length. It could be a blue light or it could be a violet light, depending on the type of manufacturing and the type of cameras they're using. So, but the idea here is that in the radiotherapy, we'd like to go with the more or like a monochromatic single wavelength kind of a pattern here, projection to the patient's skin. Yeah, different vendors that go a little bit through the different routes. So this is a system from the Catalyst. Here, instead of having two cameras and doing a stereoscopic, let's say, reconstruction, they go more for like a laser light scanning. So you have like a strip of light that you project onto the patient's surface, and then by distorting that strip of light, you'll be able to visualize or take a 3D curvature of the object. So it's more like a scanning technique than like a full 3D reconstruction technique. But of course, this is also valid, and you can utilize this to reconstruct a 3D surface as well. Both of the methods have its own upsides and downsides. Not going to go into too much detail about this, but you're welcome. We're welcome to discuss this later or with specific vendors. In principle, so when the SGRT gives you a surface reconstructing, this is what you're going to see. You're going to see kind of like a reconstructed mesh surface. So this surface consists of points, kind of like a triangulated point. So each point on the vertex of those triangles are the 3D reconstructed point, which with its XYZ coordinates. And you'll be able to visualize this mesh, and then you can render this either as a point cloud or like a mesh surface like this, or you can either also see, say, a surface, let's say, video rendering, including the surface physical features superimposed on that surface too. Just to talk about what the operation principle is, so this is an example from a line RT system from VisionRT. Again, in a clinical setting, like in a very normal CM bunker, similar to this, or it could be also an electrolyte, depending on the configuration, you will have 3 camera pods placed around the patient's body. So you'll have 2 camera pods in the lateral side of the patient, and you have 1 pod from the foot of the couch. So those project this speckle pattern, and this is what the cameras themselves see. So they see the real-time stream of video information in infrared range, where they can discern a speckle pattern of the patient. This then, in the end, is reconstructed by the algorithm and chopped out in, let's say, in the frames and reconstructed as a 3D surface. And this is why you kind of need multiple camera sources in the bunker, because as you can see, none of those single cameras would see the full picture. So if you have the camera on the left, you would see the left side of the patient, but the right side would be obscured or blocked by the patient itself. So only by combining sources from multiple angles, you will be able to see a full 360 view of the patient, and be utilized that through 360 view to monitor and position the patient as well. So after that, after we got the 3D surface, of course, this won't be only it. I mean, if the only cameras were able to take the 3D picture, or the patient would not be much of the benefit from them. So we are utilizing this surface, and we're matching now to some kind of reference. And the best reference, it turns out, at least for initial positioning of the patient in treatment, can come from your CT sim. So whatever way you scan your patient, whatever way you generate your external body contour in treatment planning system, you can go ahead and match your live reference to that contour, and you can discern what is the position of the patient in real time. This is done by the fusion, or doing the fusion of your live surface here in green with the pink surface here. This is your reference surface, and by doing this fusion or live registration, you can calculate the deltas, and you can calculate what are the shifts between here. So after that, you'll be able to discern the patient's shifts. So you'll be able to calculate what the shifts are. Here are shifts from all different degrees of freedom, and you can calculate those shifts with respect to the treatment as a center directly. So this is what you get here, and this is the view from a line RT, where each of the deltas represent where the patient is compared to where the patient's supposed to be with respect to the treatment ISO. And if you move and rotate the patient in similar manner, you'll be putting the patient in the same treatment ISO center. So this is the idea behind it. So we can see and detect the patient's position, at least in treatment in real time, using this technology without any added downsides, like no X-ray radiation is here. It's fully optical system. You can have it turned on all the time, and this information could be coming to you completely in real time. So calculations in the fusion, as I mentioned, done in real time. The accuracy of that fusion is 0.1 millimeter and 0.1 degree. And the frame rate where the fusion and matching is done is about 27 times per second. And this is for a LineRT system. So you can really trigger and see the patient's motion as with the frame, with the latency as low as 50 milliseconds with this approach. There are a lot of commercial systems now on the market. Different systems offer different approaches. Some vendors, let's say, create the systems only specifically for treatment side. Some vendors have solutions here also for the simulation. What I have here in mind, at least from the VisionRT solution, we are actually giving you a much more larger cohort of SGRT systems, not only used for treatment, but for simulation, planning, and imaging of the dose directly. So I'm going to talk a little bit about this at a later stage. And this is kind of ties in very nicely with our current definition of what the SGRT solution is in radiotherapy and what it means to have solution for radiotherapy. There's also dedicated solutions for some specific geometries, like Halcyon and Ethos in this case, where you have, let's say, two isocenter system for treatments, where you have a solution for setting the patient outside using those ceiling cameras, where you have the setup isocenter, and then for treatment, here you have a miniature cameras arranged as a ring, put into the gantry of the closed bore LINAC accelerator here in this case, where you can monitor the patient in 6 degrees of freedom inside the bore, and you can utilize the same kind of workflows you can use for the open gantry LINACs. Just to showcase you what this looks like. So here is like a miniature camera insert for the Halcyon. Here's engineers going in and attaching this ring cameras. There's a single cable connected to them, delivering the power, and you can expand and fit this ring into the bore of the accelerator, and you'll be monitoring the patient as the patient goes in for the treatment. So this is for that specific type of closed bore LINACs, the SGRT system developed for this. So you can use the system honestly for any type of treatments you can are doing in a radiotherapy clinic. Now, if you go to a PubMed, you type, let's say, SGRT, VisionRT, or AlignRT, you'll find now close to 250 publications discussing on different treatment sites, accuracy, and clinical outcomes, and whether this is anything superficial like breast or chest wall, down to pelvis, extremities, cranial treatments, and you name it. You can really use it for anything. There's almost no downside to this technology. A big aspect of an SGRT adoption in a clinical setting is the patient setup. As I mentioned, we can utilize the surface-based technology in treatment for aligning the patient very precisely alongside to what we had during the scan. And this is the kind of a AlignRT, VisionRT solution for this specific purpose. And in this case, we're utilizing SGRT now for something called the tattoo-less and markerless radiotherapy, where we do not do any more permanent tattooing and marking of the patient at the CT sim and aligning later on the lasers, but we rely specifically on the SGRT for full-on patient setup. And this is what I mean here. So here you have a feature called the postural video. So this is the license feature within AlignRT Advanced platform, where you are seeing the live video feed from the cameras inside the bunker. So you have 3 cameras, then you have 3 different views and vantage points. And what's superimposed here is, let's say, these outlines are automatically generated from your reference geometry. So whatever surface you import into AlignRT system from your treatment planning system, that surface, that outer body contour will be automatically transformed into the outlines, and you can go ahead and position the patient according to that. And you can see immediately where the patient's arm's supposed to be, where the chin needs to go, where the torso needs to be aligned, and you can go ahead and do all full-on patient postural alignment on the table without relying on tattoos and marks, and you can align not just the target treatment areas, but any other ancillary areas you might have on the patient's body. On the other hand, you have the real-time deltas. So now they tell you where the patient needs to be and where the patient is. So they can use this real-time deltas now to put the patient directly at the treatment isocenter. And this is done sometimes also automatically. So here's example of extremity treatments. And you can see there's no marks or no immobilization on this. The RTTs are going in. They are, let's say, adjusting the rotation of extremity in real time. You can see the deltas are also changing for the roll in real time as the adjustment is done. And the other deltas then are automatically sent to the couch. And the couch then is driven by one push of a button through the couch interface to take the patient to the treatment isocenter directly. Here you can see the RTT kind of therapist cycling between the views. She sees the leg is positioned well enough for treatment, and she can go ahead and treat this patient. So all of this nice, quick and easy semi-automated setup workflows are there for the markerless solution. Here's a bit of an example for treating the chest wall. And this is the right chest wall patient. Is being treated through the VMAT. Again, a markerless and tattooless based setup. Here, utilizing SGRT. So you can see the therapists are looking at the deltas. They switch to the postural video view. They go to one of the lateral cameras. They see, oh, the patient's arm is a little bit down. You can go ahead and kind of pull it up here, correct the position of that. And when the position is corrected, we can go ahead and deliver the treatment like normal. So we can go ahead and watch the patient in real time. And the idea is also that we have a connection to the LINAC. And if patient starts to move outside of the tolerance, we'll be able to automatically hold the beam while patient is being treated. So this is the system is watching the patient now in real time and facilitates automatic beam hold delivery through the whole process. Some of the other features besides tattooless setup, so SGRT system can within AlignRT Advanced has this feature to look for anatomical changes or quantify anatomical changes of the patient during the treatment. So if we have some swelling of the surface, it's quite common for the breast, or some receding surface, or the weight loss in blue here, we'll be able to kind of color code this on our specific surface area, but also we can quantify it. So for example, here it says that 93% all your target areas within 3 millimeters tolerance from your reference, and everything outside or above here, like swelling, is visualized in red. And you can do it similar for the blue as well. And then you can also visualize and see this not just for your target area like breast here, but you can visualize this over for the full field of view of the camera. So besides your original target. Some of the clinical examples I like to give. So here is the breast swelling example. You have the breast swelling here seen in red. So you can visualize this going on with the patients, also verified later down the line by the imaging. And here's one other example that this is the picture. I took one of the trainings, so this is the chest wall patient post-mastectomy that has quite a large bull area in the middle of the chest wall. And this is actually where her scar ends. So in the middle, this is where her post-mastectomy scar ends. And the area around that scar receded significantly from the point of simulation. And you can visualize this on utilizing this feature within SGRT, or you can detect those kind of anatomical changes going on. Moving on into some more clinical applications of this technology. One of the current widely used techniques with SGRT is treating DIBH, especially when it comes to left breast radiation. And I'm sure you know why this is important, because if we are, let's say, inflating the lung, not only your chest wall and radiated area moves away from the heart, so there's not added dose to the heart and no later complications, but also, let's say, amount of lung you radiate also decreases. So this is quite beneficial technique for radiating left breast and preventing further down cardiac complications. So one of the publications that looked for those specific clinical outcomes on heart toxicity was this paper by Ziger and al. Was published 2017, which they looked at the cardiac toxicity for left breast with and without line RT. So they did SPECT-CT scans on their DIBH patients being treated with the line RT prior and after the radiation, 6 months, and they found out that at the follow-up, they didn't see any of the worsening of the cardiac perfusion scores, meaning they didn't see added heart damage to the patients from left breast radiation. So this is quite surprising for them. They went into to dig into the literature, and this is a quite large review paper published by Duke University. This is Marks et al., which found out this number can be as high as 27%, basically 1 in every 4 patients getting some heart damage, additional heart damage due to left breast radiation, if you perform is in a simple rebreathing manner. So again, this is a quite number. But reduction of this heart toxicity was a big thing. This paper was published in a Astrovet journal, and since 2017 and onwards, SGRT has been considered to be a standard for those types of treatments to be able to deliver the DIBH with an SGRT-based guidance. Just to show you how it works in a clinical setting, so we are taking a free breathing and breath hold surface, and it's quite easy to see why free breathing surface, because you can do full on patient's postural alignment while patient is fully relaxed on the table. So you can use the free breathing surface for this, and then you can kind of switch then to the breath hold surface. You'll see now immediately that the patient's chest needs to be extended. You coach the patient to the breath hold, you verify that the breath hold level is the same as from the simulation, and then you gauge the patient's beam in all 6 degrees of freedom. It turns out, and there are many publications looking at it, so this is a very reproducible method to do DIBH, and not only it's great for breast or chest wall, it's great for any other type of DIBH treatments, whether you're doing breath hold treatments for lung or liver, especially when you're performing this for the SBRT type of delivery. So you can actually get a very nicely good reproducible results from here. Just to showcase you how this works in a little bit, so I'm going to show you a short video showing the DIBH procedure on a line RT advanced solution.
The breath hold technique is used when treating sites that can be affected by breathing motion, such as lung, abdomen, or breast. For left breasts, deep inspiration breath hold is commonly used to minimize cardiac toxicity. This treatment method is proven effective at preventing cardiac perfusion defects when used for heart sparing in left breast treatments. For breath hold patients, Align RT Advanced provides a fast, streamlined, and intuitive experience while enhancing patient safety features. Successful breath hold treatments start in simulation. A free breathing and breath hold scan are used. The free breathing scan is used for initial treatment setup and allows the patient to be positioned comfortably without holding their breath. It also sets the couch position, ensuring separation between the heart and chest is achieved via breath hold. The breath hold scan is used for final setup and treatment. Once the breath hold plan is completed, approved, and imported into Align RT Advanced, the initial positioning in the treatment room begins using the free breathing surface. Align the patient to the general location of treatment ISO center, then use Align RT Advanced SGRT technology to begin monitoring for patient setup. For optimal patient setup, the user can first utilize the Align RT Advanced postural video subscription feature to ensure the patient is in the proper postural position. Postural video provides outlines of the reference surface superimposed onto a live video stream of the patient, showing a real-time view of the patient's overall alignment relative to the reference position. This is a great tool to visualize the patient's postural alignment at the ISO center position, as well as ancillary surfaces such as the arm and chin. The user can see a camera eye view from all three camera pods to ensure the best postural alignment possible. Once gross misalignments have been resolved, fine-tune the patient setup using the real-time deltas, which demonstrate where the patient currently is and where they should be in real time. The real-time deltas generated are based on the selected ROI. Continuous real-time feedback facilitates a fast, accurate setup that reduces the need for repeat imaging. Next, switch to the breath hold surface and coach the patient to reach the proper breath hold. This can be assisted by the real-time coach. The real-time coach supports the patient in achieving the proper breath hold. It's positioned so the patient can easily see the screen. This tool helps the patient better visually understand if they need to take a deeper or shallower breath. The patient has achieved the optimal breath hold amplitude when the moving bar is in the middle of the white threshold window. Once the patient's ready to treat, mode up the LINAC and instruct the patient to take a breath in and hold. When all real-time deltas are within tolerance, treatment can commence, and Align RT Advanced will continue monitoring for intrafraction motion management throughout the treatment. Because Align RT Advanced has the ability to monitor the patient in all 6 degrees of freedom, if the patient attempts to arch their back to achieve the correct vertical displacement, Align RT Advanced quickly identifies the position is not the same.
So I'm going to pause a little bit here and talk about why SGRT has become a little bit of standard for such type of treatments. And one of the reasons is this. An idea here is gating in 6 degrees of freedom rather than specifically gating on 1 degree. So in the past, a lot was of the very user in the past, we did use a marker block specifically placed on the patient's body to be able to detect the breath hold level. And we would measure the vertical displacement of this marker block and be able to kind of watch or gauge the beam using this kind of amplitude 1 degree of freedom approach. The issue with that specific approach is that it does not truly translate at all cases. It correlates a little bit with the breath hold, but not completely, and it does not always translate to a true inhale or expansion of the chest wall. And the reason is for this. So for example, here you can see the patient, instead of taking in the air or expanding the chest, they are trying to back arc, or they're trying to kind of lift up their lower body using the back muscles. So if we're doing now, let's say DIBH with the marker block based approach, we'll be able to see that the vertical position of the chest wall comes into the tolerance. So in principle, if we're doing the gating in 1 degree of freedom, we'll be okay to be mount. On the other hand side, we can see that other deltas, especially here, the pitch is detected, the non-zero pitch delta, and tells us the patient is actually back arcing. So in case of a line RT, we'll be able to prevent this because we are actually gating in 6 degrees of freedom on specific position of the chest wall and the breast. So in case of, let's say, a one-off gating on the vertical, will be, let's say, beaming on in such scenario. This is preventable, and we prevent it at all costs, because if we look at the dosimetric outcome of this, means that the heart and the chest wall are not separated, and we're pushing more of the heart and more of the chest wall into the radiation field. So this will give us even the worst clinical outcomes than even doing the treatment in free breathing. So we want to prevent this at all costs, and by preventing this at all costs, looking back at the clinical outcomes from the previous paper I discussed, we can really reduce toxicity on the heart down to the 0%, meaning that we can actually prevent those incorrect, or I would say mistreatments, or cases where we could have the patient not specifically going into the inhale. This, of course, needs to be taught, and patient needs to be coached. So they need a bit of a visual reference to be able to see where they need to go and how much they need to inhale and where they need to hold. And here's the visual reference interfaced wirelessly with the cameras. So you can see that when the bar goes to the white threshold area, patient is aware they need to hold the breath there and maintain that position during the whole treatment. And since normally the beam is automatically gated, the patient can actually control their own treatment. So they can inhale, hold, they know the treatment will start, and when they're ready to relax, they can relax, and the treatment will be automatically paused. Another really big, let's say, usage of an SGRT system in treatment is using those for more precise treatments like cranial SRS and SBRT, where for cranial SRS, you can utilize open face masks with live monitoring. And for SBRT, you can use the surface for patient accurate setup, as well as interfraction motion management, as well as the DIBH coaching, if such thing is indicated for SBRT. For this specifically, just to give you an example how this looks like, so here's the short discussion of the workflow for the stereotactic cranial delivery. So you can use SGRT for initial fine-tuning of the patient setup. So even before you apply the mask or you put the open face mask on the patient's body, you can actually correct the patient's head position using the postural video. You see the nose bridge, you see the deltas, you see the shoulders, you can actually correct for those. After you perform your IGRT protocol, after the mask is put on the patient, normally for SRS and SRT, it's a CBCT, and you perform the image registrations. You can actually, after the couch shifts are applied, you can capture that position with the cameras at this point after the shifts have been applied, and then you can track that position in real time during the whole delivery. Even if your couch is rotated and where you don't have anymore the OBI component, you can actually still track the patient in real time without any added X-ray radiation. And this is, again, a real time, and the reference is rotated according to the rotation of the couch you have within the plan. And since this continuous monitoring, you can also enable the beam hold, and you'll be able to hold the beam if patient moves out of sight of the thorax. Just for the sake of time, I'll just kind of skip over this video. Here's the head adjuster accessory that sometimes we also use. And this head adjuster gives the ability for you to correct for PRS and pitch and roll and yaw rotations of the head manually together with SGRT. If you do not have ability to have a 6-dot table and correct for those misalignments yourself with the table imaging, you can do it with surface guidance and the accessory like this. Another really nice application for is the maskless treatments for head and neck. So we can utilize now the reduced mask immobilization for head and neck patients. So here's some of the clinical publications results from here, treating the maskless patients. And this is, again, the slide from the talk by Mike Tollhammer. He's a medical physicist, chief of physics in Denver, Colorado, and they're using this chain strap mobilization to treat head and neck patients, full alignment and the treatment, including the neck nodes. So this is again a slide from his presentation for the SGRT community meeting, and here it sees that that the shifts from this chain strap mobilization are not higher than even the, let's say, normal mask or open face mask. Sometimes they are even better. Sorry, apologies. And the treatment time between patient setup and treatment is about 8 to 10 minutes, like with the normal mask. So you can opt out for less mobilization and bigger patient comfort. A lot of data for utilizing SGRT for pediatric patients and reduction of anesthesia for pediatric patients. Here's this publication from Alk and al. At 300 patients treated. And there's also one additional trial called the PROMISE trial, where they are utilizing, let's say, transparent screen here with the projector to show some cartoons to the children while being treated, and if they start to move on the table, this is paused, and it incentivizes the children to stay still. And they found that they can reduce the need for general anesthesia by a lot, or even for the kids as small as young as 3 to 7 year old. I mentioned a solution for the board-based Linux that consists of ceiling cameras and inboard ring. And the accuracy, of course, is quite improved for these types of Linux, because those Linux, especially Halcyon and Ethos, do not offer you rotational corrections. So there's no yaw, pitch, and roll corrections for patients' positions, but you can do it with SGRT. And when it comes to patient-based setup, you can get time savings as well as more accurate setup without any residual rotations, which shows very well on post-IGRT shifts, where you don't have any more large shifts stemming from the residual rotations that are kind of translated into the large shifts. There's some people doing some of the research here, that this is the kind of a research presented by the Hamad Center from Qatar on their inboard, and even there with the inboard solution, they see a 5-fold reduction on their residual pitch, as well as the reduction on the total treatment time by 25%. The inboard solution is quite important, it turns out, for the for those types of Linux, because we see a lot of interfraction motion, and this is the publication from University of Leuven in Belgium, where they looked at the interfraction motion of the patient and see that there's a non-zero significant drift for most of the patients treated on those Linux, and for more than 75% of those patients, this drift is monotonic, meaning the patient continue to move outside of the tolerance, really driven by muscle relaxation on the couch itself. And those drift can be as high as 3, 5, or 7 millimeters. And this is really important to be able to visualize, because we can be doing adaptive workflows on those types of Linux when we're delivering those types of treatments. AlignRT is a big component for proton machines, because motion management is important there, especially for those types of deliveries. And as the publications say, not we are reducing the residual shifts post IGRT, but also we by a factor of 2 and 3, we are actually also reducing the average setup and treatment time from 11 to 6 minutes. Going on further down, so this is again a solution for the CT SIM, but it's a fully contactless solution which we utilize for simulations here. So we are taking in the patient surface, we are selecting any point on the patient's surface body, and we can record this from this point, a breathing curve, and we can utilize then this breathing curve either for facilitating for DCT or DIBH workflows in a clinical setting. And can be done. We can do like for DCT reconstruction retrospectively, or we can coach and train the patient for DIBH without any specific added device. And this is a single camera solution for the CT. A lot of guidelines are there. So just quickly talking about the commissioning and QA of the systems. There are now guidelines both from ASTRO and TG302. This is the new guideline from AAPM about SGRT. They talk about routine QAs and commissioning process and procurement QA of SGRT systems. Some of the, let's say, QA processes tests are outlined here for commissioning, like ambient light, field of view tests, thermal stability, dynamic accuracy when we are blocking one of the cameras with the gantry, etc., and any type of end-to-end testing you can facilitate in a Since the system is optical, we can facilitate, let's say, full-on radiographic calibration. With VisionRT, we have a specific cube that you can set according to your lasers. We can take the pictures or NV images of this cube, send to AlignRT, and do on retrospective, let's say, I would say on-light calibration. So first we start with this pattern-specific plate to define external isocenter, like with field light or markers. And then we can use this cube and radiographic analysis, which is done automatically, to calibrate and fine-tune the isocenter of the LINAC directly to the MV ISO and the SGRT isocenter of the AlignRT to the MV isocenter of the LINAC specifically. So it's again a nice automated tool for cross-calibrating radiographic ISO and optical ISO. At the modern definition of SGRT, I talked a little bit about, quite a bit about treatment. I talked about some of the simulation, but there are two more components now into the SGRT family, where there's an SGRT now for planning, as well as the SGRT for monitoring the delivery of the dose. I'm going to just quickly go through them because I think I'm almost out of time, just 5 minutes. We're utilizing this clearance mapping solution, which is the solution that we utilize in SIM. We have additional 2 cameras that capture the patient's full geometry prior to simulation, prior to scanning, and we can put that geometry into your 3D scan bunker and generate a full-on non-coplanar treatment field. Treatment clearance map, where red areas show the collision areas between the patient, the gantry, or the couch, and the gray areas are the areas safe for delivery. So we can check your simulation, we check your plan as well for collisions and delivery, safe delivery. This is what it looks like. So on x-axis, this is couch angle. On y-axis, these are the gantry angles. So the vertical lines represent the arcs, and the points represent the 3D or IMRT fields. And this is kind of what you will see as a 3D representation. You have a 3D model of your LINAC, and the patient is put into the model, and you can check your full treatment plan against the collision and the clearance. You can utilize for a few things. You can basically check the patient's position at the SIM prior to scanning, if it's good, or you can see some collisions down the line. You can completely avoid dry runs and any kind of clearance issues on day 1. And also in the planning, you can opt out for non-coplanar plans, more let's say planar beams, and you can get better tumor dose and lower normal tissue dose with this. Going further down, what's important when we did a few of the tests, initial clinical tests, we found out that the planners were only, let's say, okay, or would say they are say okay to opt out about 2/3 of deliverable fields. They would say they're safe to deliver, but there would be missing at least 1/3 of possible options to them. So MapRT opens up more space for delivery for you. What it will look like for case studies, we're just interfacing with some of the TPS vendors here that can take in the MapRT information, and here they can check the collision, say, I would say the status of their non-coplanar films directly. They can change their gantry or pouch angles, and they can see if this field still has a collision directly in the TPS here. And this is another case study where the patient can lift the arm, but with the rotations, like 10-degree rotations, we're able to really meet all the dose constraints, and we'll be able to deliver this plan safely because we checked the plan on MapRT. Just 2 more minutes and I'm going to finish. So this is another aspect of SGRT solution, which is the dose monitoring solution in the clinic. So we are utilizing now Cherenkov imaging, where we are adding additional camera to your SGRT cameras that sees the specific chunk of light that's generated off the shallow depth when the radiation enters or exits the patient's body directly. So we can see this here, and we can visualize the real-time dose fluence on the patient's surface. Test that about 10% of patients or fractions have some kind of issues in delivery, dose delivery that can be caught by those RT solution. And here's some of the other things going on. Here's the contralateral dose. So contralateral breast get the bolus placement versus the radiotherapy field, where you have a bit of a mismatch sometimes between where the field needs to be and where the bolus is placed. Here's another option of patient pushing down the arm, and you can see this as well during the delivery of the radiation in real time. And just to show you that this is the real time, you see dynamic Roger factor of jaws closing in real time. So all of that you see in delivery when you're delivering those to the patient. Some other options here: delivery of the dose to the breast. You can see dynamically, so dynamic fluence, and this is the combined fluence result for the first fraction, and this is the result from one of the last fractions where the patient arm is a little bit down, so you have an exit dose to the arm and a bit of a shadowing under dose here in the upper quadrant of the breast. MLC being open during the, again, a planned delivery missed by patient-specific QA, or the dose going through the chin during the thorax delivery, which can also be seen in the planning system. It works for under the mask, and it also works for MLC profile that your life was also the combined fluence. You can see all of that information at your fingertips in real time as you're delivering the dose. And this is kind of like a combined product where we are working on of having a SGRT solution, watching the patient's position, as well as watching the dose on delivery. Okay, I'm gonna kind of stop here, just quickly mention the challenge there. Of course, SGRT is not a magic stick or magic wand. It does not solve all the problems. It has its own specific challenges, including that, let's say, blockage effects with a gantry to the surface. But all of this can be mitigated, and in the end, combining SGRT and IGRT works the best as for a solution in a clinical setting where you can get the best of the both worlds. Okay, thank you. I'll just stop now. I think I've went much more over my time.
Thank you, Irakli, for your valuable presentation. Actually, you tried to summarize all the applications that register in radiotherapy, not only IGRT, but also during planning and validation of those deliveries during treatment. So, thank you for this valuable presentation. We can hear now from our team if there is any questions. I know it's a new, for a lot of orthopedics for this modality technology. We can hear from them now if there is questions for 5 minutes. If not, we will put the presentation in our ESS channel playlist, and then we'll make a post so that Sadiq can go and ask any questions you directly. Irakli, I think you are in our Facebook groups, is it?
I think, sorry, I'm muted. So yes, I am inside the group. Also just I'm also put my email address in the chat, so you are most welcome to send me any questions.
Thank you.
If you have any questions, maybe beside time, and I'll be happy to answer all of them. And you're also welcome to connect with me on the.
Okay, thank you, Irakli. So I think in the clinical situation,
I think
of patients treatment.
Yes, it's quite common workflow. So we do so SGRT and IGRT kind of work hand in hand. So normally, what you would normally do is set the patient according to the SGRT. You would correct your residual deltas as much as you can. So bringing the patient close to your golden standard or golden position that you had from the sim or your plan. Then you would perform your IGRT protocol, depending on what you're using. Could be a CBCT, could be a KV planar imaging or KV-MV imaging. And after the shifts are applied to the table, you can actually capture that position with the cameras in a 3D manner. So you will be capturing the full surface, you will be zeroing out your deltas, and you'll be monitoring the patient in real time from that position onwards. And you can monitor even if you have an oncoplanar delivery, or if you're shifting the couch, rotating it, you will be still monitoring the patient in the real-time manner with this. So yes, that is a very common workflow.
دي فرض pictures لو في أي أسئلة So if not, as we mentioned, we need to post also after loading the videos, so that you can provide the presentation and go in more details about this technology, and can ask the effect on the or directly contact with Irakli about any inquiries or questions regarding this. Okay. Thank you.
It's okay. I think, yeah, okay. Yeah.
You want to say anything?
Yeah, I think I got another question, but I will answer I will answer in the chat. That's fine. You can
I think you are
proceed with
now. So thank you, Irakli, again for your valuable.
Thank you.
We will try to cover all the